Go ahead and talk about your fun poll.
Okay, hi, my name is Megan Toscano. I'm the project assistant at WVU. And so my little announcement is that we have received a grant for addiction medicine, and we'll be providing some web-based and in-person trainings. So some of those trainings will be like short video clips that'll be posted up on a website. And we would just like to get your guys' input on what clinicians are interested in. And so we have a list of topics that we're going to be polling you guys today. So whenever Caitlin puts that up there, it should pop up on your screen just to get an idea of what you guys are interested in, what you guys would like us to film.
Thank you, Megan. All right, guys, so you're going to see a poll here in just a second. If you guys can take it, you should be able to select 3 options. We'll just take a minute to do this. And if you don't see something that you want to see, just send us a chat and we'll add it to the list. Does everybody see it, or is anybody having trouble with it? Oh,
we don't see it here in Canal City.
Oh, okay, I'm sorry. Are you guys on a computer?
Yes.
I'll make sure to send it to you afterward.
Okay. All right, thanks.
Yeah, thank you. So just a couple more seconds and then we'll show you the results, and then of course we'll use these for what Megan said. All right, guys, thank you so much. I'm going to show you what everybody's, can you guys see that? What the totals ended up? Methamphetamine treatment was super high.
That's not surprising.
Good to know.
No.
All right, thank you all for that. Okay, cool. So from here, we're going to go and start with our first case presentation. Jeremy, do you mind to start? Is that okay if we share your case?
Sure, yep. Ready?
Yep, as soon as we get it up, whenever you want to.
Okay, so today I wanted to talk about a client at our clinic. He is a 24-year-old male with Medicaid, MCO insurance, brief family history. Both parents were active in addiction. Father is deceased due to liver cirrhosis. Mother is currently still in active addiction. This client in particular was an IV methamphetamine user since age 15 and IV heroin daily for the past 4 years since age 20. He's had 2 residential stays in treatment back in 2011 and 2012 as an adolescent, and relapsed almost immediately after coming back out of both of those. 4 recent overdoses requiring Narcan, most recent in January of 2019. He came through our crisis stabilization unit in August of 2019. We put him, due to the history and needs, we put him into our IOP and Suboxone MAT program. He did really well in the IOP this time, successfully completed that in November, and is currently in the weekly MAT group with no relapses still since September 2019. So we've had a good couple of months with this client in particular. He had a MRSA infection in his hip. He uses crutches due to pain daily, and he's in need of a hip replacement surgery. In the past, he's had a couple of these scheduled. He had to cancel it due to the surgeon canceling it or himself canceling it due to his ongoing drug use, which he didn't have much clean time in the past. Current medications is Suboxone 8 milligram daily and Lexapro 10 milligrams daily. He does have major depression, recurrent and chronic. So my question was, with this case is, or our question, is actually came from one of our team members who's a counselor. She submitted it to me when I asked them if they had any questions, was that the client is readying to do the hip replacement surgery. He's very worried about pain levels post-surgery and whether narcotics will be needed. Due to his history, this is the longest clean time he's had built up. He really doesn't want to, but he's very of the pain that he might be having. His questions and her questions, will they think Suboxone will be enough to manage this pain post-surgery? And if not, what plans have others made in similar situations to mitigate risk of relapse when narcotics are needed after surgery?
Awesome. Thank you so much, Jeremy.
Sure. Yep.
I'm going to ask everybody out there, everybody in the field and the rural primary care clinics and stuff, what would you guys say or do for this person?
Well, we had a similar patient. He had leg surgery and he also had I think a neck fracture from that. So what we did with him, we continued the Suboxone. We went up a bit on it. At first he was okay, and then he needed more relief. And so then we did add in PRN. Keep in mind the perioperative period was around like maybe 2 weeks or so. And so we told his orthopedic doctor he might need more than usual. So instead of, like if he needed the narcotics, he needed, like instead of giving him 5 or 7, he probably needed 15 of the oxycodone Q, like I think it was, we gave him twice a day for about 2 weeks in addition to the Suboxone. And then when he was out of the perioperative period, wean him down off of it. You know what I mean? So I mean, so that worked. Then we had another guy, but he was on Sublocade, so he was fine.
Thank you so much, Dr. Bo.
Did you have any problem with increased cravings or anything after that period when he used the narcotics after that, Dr. Bo?
Yeah, so we needed to keep his Suboxone up a bit. So I think he moved from 12 to 16. And then when he was out of the perioperative period, we stayed a little higher for him. Then we brought him back down, back to his 12. So I think naturally that he would have, your patient might have more cravings because he will be exposed to narcotics. If the Suboxone increases and it doesn't work, I mean, that's okay. You just give him a higher dose, cut off the cravings, then when he's ready, bring him down a little bit.
Thank you.
Thank you. Any other comments or thoughts?
Yeah, so the other thing that some of the psychiatrists have told me is you can split the dose, and that seems to help. And paradoxically, I've had some patients lower their dose and get better pain relief, but not as much addiction relief. And I was reading, I don't know, the lower doses is what we use for pain. So, you know, but I've just had them split it mostly.
Yeah, you're right, because under 8, actually all of his pain receptors, well, most of it will be occupied. So he'll probably get pretty good pain relief compared to other people who are not on Suboxone.
Dr. Baltier. Dr. Morrison, did you?
Yes, first I just want to say that I'm really glad this case came up, as we have some similar ones, and I would do the same thing you've done. I'd present it because I wouldn't know what to do either, but I know some things that I'm not comfortable doing in situations like this, and one of them is going above 16 milligrams Suboxone in any case, and I'm feeling a bit awkward about trying to do any combination of Suboxone with other opioids like controlled 2s in combination. And what I run into every time I try this, I get challenged to be there at the time that I need to be there for the patient when the pain is uncontrolled, where I'm in an outpatient clinic. So I had one really good experience where I was glad it happened that the surgeon just absolutely insisted the patient not stay on Suboxone and switch to opioid, so the surgeon could be there for day-by-day follow-up and just manage the opioids. I think ideally the person stays on Suboxone. There's a recent law actually where called Jesse's Law about a woman who had named Jessie who received like 50 tablets of oxycodone to manage the post-surgical pain and used it all and died of an overdose from it. And so they attempted to, the purpose of the law was to try to shift us towards sharing information about addiction more freely with hospitals and surgeons, but it ended up watered down. But it does demonstrate that this is a really difficult problem to deal with.
And then for our C-sections, what we've been doing is what Morgantown recommended, which was keep them on their dose, even if it is 16, and then give them 2 to 4 milligrams of additional buprenorphine, and they've had to pay for that themselves. And I usually set a limit of days. And so for a C-section, it's 3 to 5 days only. And so for a hip replacement, you could set some type of limit like that as well. And then, you know, for the other doctors, I know they don't want to do it, but legally they can, when the patient's in hospital, they can continue to prescribe. I know they don't, you know, they want us to do it, but I think we need to push back a little bit gently. We want to be there for our patients, but it's also, you know, building up their comfort level. And most of our, you know, our OBs are getting a little more comfortable with what I just said, that standard. And so then they call me when it's out of the usual, but they usually call me once and then they manage it and go from there.
Thank you, Dr. Boss. All right, guys have.
Let's say, I mean, this is a very real life example that if you're doing MAT long enough, then you're gonna face this one way or another. And I could, from our experience, really just increasing the dose of Suboxone and or increasing the frequency, so splitting it up into 3 times a day, seems to really make a difference in helping people with pain. And we've had folks who have had major surgeries doing it this way, in addition to NSAIDs and Tylenol as well. And people tend to do pretty well. And what's good about it is they come back after doing this and then share their experience with the rest of the patients. And everyone else understands that, wow, when I was in active addiction and I had been on my regular opioids, nothing seemed to touch the pain. Even more opioids seem to touch the pain. But now that I seem to be in recovery and stable dose of Suboxone, my pain can actually be controlled with legitimate means. There's a number of different strategies, and so some of our colleagues across the country will do what Dr. Bowe is doing. They'll continue with some of the Suboxone and then add another opioid on top of it to manage the pain acutely for a short period of time. Some others, and I've done this before, that if I've had a surgeon that's just not comfortable continuing with the Suboxone, stop the Suboxone that day or the day before surgery, and then let the surgeon manage the pain they would with their other controlled opioids, substance opioids, and go through that process and then just restart the Suboxone when they're done with that. I would say that if you are going to give somebody with an opioid use disorder more opioids, at least not buprenorphine, then whenever possible, if you could have somebody in their life who's with them, who's able to help keep them accountable, maybe that they can watch and keep the medication. Just because I've had so many patients who, once they do get that full opioid again, a lot of the bells and whistles are going off in their head. They don't like it, and it scares them. And knowing that they've got somebody else in their life to help them stay on track can just be a good lifeline and help everybody feel better overall. So that would be the one additional thing I think worth considering, is having somebody else who can hold the medication and distribute it when the patient needs it, if you're going to prescribe another controlled substance.
And it's such a good thing you have this patient's already involved with an individual therapist, because they can help them be there during the recovery period and walk them through some, mindfulness-based practices to help with that.
Yeah, that was my next question. If anybody had changed the frequency or the intensity of the counseling or behavioral interventions to prior.
Yeah, absolutely. If it works with the individual therapist schedule to be able to see that patient more frequently, that would probably be best timing for that.
Okay.
Jeremy, did we answer all your questions? Anything else we can help with?
No, I think you got them. Thank you.
Perfect.
I think
Thank
Dr.
you.
Bo was going to say something.
Oh, Dr. Bo, did you want to say something?
Yeah, hey, Jeremy, I was just going to say, if in the inpatient setting, you have to overcompete your buprenorphine because it's not working, you can tell them to use either fentanyl or Dilaudid or IV buprenorphine, okay? And those usually, I mean, I've had 100% success with that. That's just perioperative though. And Toradol works better than ibuprofen and Tylenol. Toradol, I mean, if you use that, it is amazing.
Yeah,
I
I
think
agree.
he's shaking his head. Yeah. Okay.
And also, Jeremy, do you have like this is a planned surgery versus a traumatic surgery, which is kind of good. I don't know how, if your patients over there do pre-anesthesia workups, because sometimes bringing on the anesthesia team to help with like regional blocks for the immediate post-op pain can help at least get over that hump of like, I'm going to wake up in so much pain. And if they don't have that, sometimes psychologically, it can help them get past perceived fear of pain.
Okay. Yeah, I think we're still in the convincing him to do it phase, but yeah, he's really worried about the pain. So yeah, when we get,
He's a young guy who needs that surgery. Did he have an infection that caused that, or what's going on?
yeah, MRSA. And
That's too bad.
yeah, so he's in a lot of pain daily, but this is the best he's ever done as far as his recovery. So he doesn't want to jeopardize that, but at the same time, he wants to get the hip taken care of. So we're in the midst of convincing him, while on the back end trying to make the plans like you all are helping us decide here. So.
Hey, Jeremy, before they do the surgery, maybe get them to decontaminate him first, because that will reduce his MRSA relapse rate.
Okay.
Thank you, Dr. Bell. And thank you, Jeremy, again. That was a great presentation.
Yeah,
We really all appreciated it. Our second case is from Lois and Ryan. Are you guys ready? Can we share that? Yeah.
We are.
Thank you. It should be under 8A1. Change the tab. All right. Yeah. All right. Can you guys see that?
Yes. Dr. Morrison?
I'll be happy to present. Yes, this is
Okay.
a 51-year-old female with Medicaid who presented recently to our clinic as a new patient, but had been to it looked like about 5 or 6 different doctors and over the last year, all managing Suboxone for her, and she well understood the risk of mixing benzos with Suboxone, but on the weekend before coming in to see me, after having previously been just a week prior being discharged from her previous clinic, I'm not certain why, she said that before we even drug screened her on the day 1 induction, she said, I've took 3 Xanax in between the last clinic and coming to yours. So basically, that's a report of 3 Xanax about 4 days prior to the day that I met her, and this was still in her urine. Historically, we have the WVU protocols from 4 years ago, or 3 to 4 years ago, and the historical protocol was if you show up on benzos, you don't get induced. But we really didn't want to do that, and over the years we've had several cases that talked about you know, that you can do it if you watch them closely. It's not unreasonable. So a big part of why I'm presenting this case is I'd like to move more towards a protocol for dealing with day one benzodiazepine induction. But what and if WVU actually has one, that's even better. But I think last we spoke, it was in a case-by-case basis. So this is a high-risk case for induction where I'm just getting feedback. And one of the things that I did that I'm not proud of is I limited her dose on day one to 4 milligrams, even though she, from the prior clinic, was taking 8 milligrams. And the reason was I didn't know her yet, and I saw all these different doctors' names. It looked like she'd been thrown out of 5 or 6 clinics, and so I had a very, very strong concern that this was a patient that was hiding a serious dual diagnosis addiction that really needed to go inpatient and was just bouncing clinic to clinic. However, the board of pharmacy for the patient, even though it showed 6 different physicians, I don't know where they work. It has their names all over the state, and she said, "I've only been to one clinic." I don't think I'm supposed to say the name of that clinic, but apparently it had different physicians coming in out of it, and she was just been in and out of this clinic several times. But even if it is just one clinic, you can tell by the dates that she had been, suspended from or left her Suboxone program like 5 times in the past year. So I was afraid with this person who knew better than to take the 3 Xanax to give her the full dose, and then be missing that she's actually potentially a heavy benzo user. Although she promised me that she has never used benzos, and that has nothing to do with the previous discharge. Maybe Lois, maybe you remember, did she say why she was removed from the prior clinic?
She said she didn't show up for an appointment and they wouldn't take her back.
Okay. So it's sort of a black box. If I take her at face value, I should just give her the 8 milligrams of Suboxone that she was on, I think, and just the prior week. And if I don't, maybe I should give her nothing. And I did this compromise of 4 milligrams, and I felt like I'd basically done the worst of both options. And so I wanted to present it here and get different opinions on how they handle situations. If there's an emerging standard for how to handle this, that would be wonderful. So I think I've pretty much asked. The key question is it appropriate to limit dose in a situation like this, or should we just withhold altogether, or should we just ignore the concerns of dual diagnosis and doctor hopping?
Thank you, Dr. Morrison, and thank you, Lois, for the case presentation. I'm going to ask you guys again out there what your thoughts, comments, insights are.
Brave man. Okay. I don't know if I would have felt bad by what you did. I think it's really reasonable. I did have a question. When you gave her the 4 milligrams, was she out of withdrawal? Was she okay with that? Or did she say, I'm still withdrawing, I have lots of cravings?
She said that
Go ahead.
I'm sorry, go ahead. She said that she was still in withdrawal and that 4 milligrams was not enough, of course. And when we gave her the initial dose, she was in withdrawal.
Okay. All right, so what we've done in situations that are similar to that is probably give up to 8 to 12 until they're out of withdrawal, but I would limit the amount. So for example, if I'm worried about someone having an overdose, instead of giving a week supply, I may give 2 day supply, then they'll come back. and then tell them, well, how long do you want to take to get off of the benzo? What do you think? And so usually, so far, we've been lucky and have people able to stop their benzo within 2 to 3 weeks. And so I just see them more often and monitor the amount we give. And so far, we've been lucky with that. I don't know what others have been doing it, but it'll be really good to come up with a protocol.
Thank you.
I have some thoughts about this. So when a patient may be distorting how much benzodiazepine they're using, you can always do a field sobriety test kind of procedure to see how intoxicated they are. So like look for horizontal nystagmus, or is there a gait abnormality? So if she were snowed by benzodiazepines, I might be more concerned about her going inpatient rather than doing an induction with Suboxone. But otherwise, my feeling is that the risk of somebody using heroin or prescription opiates for their opiate addiction on their own versus being prescribed Suboxone, I think Suboxone's a lot safer, and they're more in trouble of overdosing if they were kind of using on their own. So I think the correct thing to do is to start the Suboxone, and so if she were in terrible withdrawal from benzodiazepine, that might also be an indication that she's using a very large amount and that inpatient treatment might be appropriate. But if you don't see severe intoxication or significant benzodiazepine withdrawal, I don't see any reason why you can't induct her with Suboxone.
She was not tremulous, and there was no speech slurring. I didn't check for nystagmus, but she did have some somewhat dilated pupils that were not very responsive to light. So my impression was just no benzos at the current time. Opioid withdrawal was my clinical physical exam suspicion.
Great. All right. Thoughts?
We've really changed our practices probably since you've gotten that manual, Ryan. I mean, certainly over the last 4 years, we've been much more liberal in our starting medication first and letting this stuff work itself out as we follow them. We'll follow them more closely, but if somebody comes in and they still have benzos in their system or reported benzos, we'll still do our best to give them an adequate dose of buprenorphine to control their cravings and keep them from going out and using something else that'll put them at higher risk. And I guess I would say too that, as far as an emerging standard, that's probably where most of the providers are going nationally, as a medication first, treatment engagement, doing what you can to keep somebody alive long enough to follow up to that next appointment. And so we'll start him on the medicine. I would have probably given him or her 8 milligrams of Suboxone if that's what she was on previously, and told her to do exactly what you did. Come back the next day or in 2 days, and let's see how you're doing, and we'll keep going from there. The times that I've resisted giving somebody Suboxone is when they've come in visibly intoxicated and really snowed. And at that point, it's been hard for me to really get a good history, that they cannot give me much information at all. And I just know that right now you're too intoxicated for me to safely give you a medicine. I want you to come back tomorrow, not intoxicated, and then we could talk about it. Other cases where because they've been using benzos long enough and they've had history of complicated withdrawal, such as seizures, such as DTs or whatever it is, I would just feel like, hey, listen, it's not going to be safe for you to try to do this as an outpatient, and we'll try to get you inpatient to do this. Now, we have the luxury where we are, where it's a lot easier for us to get somebody inpatient than it is at some of the sites that you all are working in. But those are some of the thoughts that come to mind right now. And Douglas, I would say, because we're working on a new treatment manual right now. Do you know, is that one of the sections that we're revising?
Katie actually just asked me that a few minutes ago, and we're going to have to check on that.
It's not one I've seen. It's not one I've seen yet. That now I don't think we're at the end of the manual yet, but it's not one that I've seen us
Yeah,
having right.
so it might be worth making a note.
Yeah, I know we have a benzodiazepine policy, but I don't know if it's actually like the induction phase of it. So we
Maybe
might
could
need to
include
add that to it. And once we get that added, Brian, we can always get that sent out to you as well.
Great, thank you very much. The policy, actually, when we were audited by OFLAC, they took our policies and they posted them as example policies. They even left Lois's name in it. So if you go to the DHHR website online, you will see our we don't induce with benzos policy, which we no longer follow. So, and I have a big pet peeve ever since ASAM this year. I watched the How to Not Get Indicted talk, and they were like, if you have a policy, you need to follow your policy or you will be indicted. And so I'm obsessed with changing this and getting this policy updated. So thank you for saying that to me, Douglas.
Dr. Morris, I did not like where you said you weren't proud of yourself. I felt like you tried to meet your patient's needs and safety at the same time, and then you came to your colleagues to talk about it. So I thought that was a great decision.
Yeah, the reason I wasn't proud is I already knew Dr. Berry would say, just go ahead with the 8, and I didn't do it because I didn't have the guts. I wanted to get his permission first, officially.
You got to get more flight time in that helicopter to get those guts.
Hey, Brian, if you all ever have troubles, I know you all have a Canarsie branch as well as away in Cabin Creek, right? So if you're ever worried about admitting someone, you can always just text or email me, because med psychers run our inpatient medicine department. We have a lot of colleagues there, and we also do our BMed department. So if you ever need a patient who needs to get in, shoot me a text or email, we can arrange it.
That's super appreciated. One thing we've run into on arranging inpatient is where we're in FQHC and the CR 42 privacy law, they're always changing the rules. We are actually afraid to send you a face sheet identifying this as a person with substance use disorder to facilitate inpatient. I'm pretty sure we're allowed to do it under some exceptions, but they make us so nervous. And so if we had some sort of encrypted backline, that would be really helpful. So if you wouldn't mind hooking me up with that. You have my email.
But also just have them sign a release and send it to our office, and it'll be fine.
Just said. Hey, go ahead. I'm sorry, Tina. Go ahead, Tina. I talked over you. Go ahead. Dr. Bowe, you're gonna have to repeat that. I rudely talked over you.
Oh, really? Okay. Ryan, what did you hear? The only thing I said was, please make sure they sign a release and tell them that you're doing that, and it wouldn't be a problem, right? Because it'll be coming to our office, which is a outpatient clinic.
Okay.
Great. Any other questions, comments, or anything that you guys all want to bring up? Anything you guys wanted to bring up?
No, these were great cases.
Yeah, they were. I really appreciate it. So we did want to show something cool that some people have been doing. So we're just going to share it real quick with everybody. It is a video, so hopefully everybody can see and hear it. Oh, great. Yeah. Here, we're gonna try and see if we can get it to,
Apparently not everybody's
heard.
hearing the video.
but we really want to show it because Cabin Creek did an amazing job with these.
They can't see the subtitles, just FYI.
Perfect. All right.
With the purpose to get my kid back with me, and I hit the ground running. My life has changed so much from that point. I mean, I was homeless at the point when I walked in here. Started the program, started doing 4 meetings a week, 4 NA or AA meetings a week. The therapy here, the one-on-one sessions, everything. Like, I started learning so much. Even at a point, what helped me the most was helping the new people that came in. I mean, if I could help change one person from staying in that nightmare of it's not even a life, it's barely an existence, and it's no way to live. Like, the number of people I've lost since I got clean is 7. I've lost 7 people in less than a year and a half. A lot of people think that Suboxone programs are bad. They think you are trading one drug for another. I can speak on that because I've done that my whole life. One to another to another. Alcohol to cocaine, cocaine and marijuana and all that stuff, to pills to heroin, name it. I have a 20-year track record here with drugs. I did not trade one drug for another, though, because all those times in my life, alcohol to cocaine, cocaine to pills, pills to heroin, my life got increasingly worse. In the hospital with endocarditis and your son being taken away from you, that's not good. And don't forget homeless, jobless, you know, that's my life got terrible, worse every time. I start a medication-assisted treatment program, and my life got, what? Better. It has changed my life, and I am so eternally grateful for it. I have my kid back. I got custody of him back completely. He is 100% mine and nobody else's, and that's awesome. That was my goal, and I crushed it. I have a job. I'm employed. I work a night shift. Every night, overtime, all the time. I volunteered for it. I take that, and I'm gonna need that. Single mom. Having my son back in my custody is absolutely the greatest feeling in the world. Like, I was on like cloud 9 forever. Like, just, it made me very, very, very happy to have him back. And he is so happy to be back. He's like, I don't ever have to go away. Nope. And I'm all yours. You're all mine, buddy. And he just loves it. And I love it. And we're just very, very happy. He's a true mama's boy. We're very lucky.
So we wanted to show everybody that. That's what Cabin Creek did, and that was amazing.
Excellent.
So cool.
Thank you so much for showing that. Just a little plug here. You can go onto Google and search Cabin Creek Health, and there's a whole about a 25-minute movie there that features some other patients and some staff, and it's really making a lot of difference in our community, we believe.
Yeah.
Fantastic.
Those were awesome. There are several other videos you guys can watch, and we wanted to let you guys know that, you know, Cabin Creek's program has, you know, been expanding, and that's wonderful. And as your guys' programs go on, we definitely want to see what you guys do too. That's all wonderful.
Yeah, and anything like this too, that I know for many of you who are starting up in communities where they're not used to this sort of treatment, and there's still a lot of stigma. So whenever would be a great example of a clip or a movie to show whenever possible in the community. And if you think of other examples to share, please do so.
That is about all I had planned for today. Do you guys have anything else you want to talk about? Any questions? It's a great session right before the holidays. All right.
Have a good
Well,
Thanksgiving.
everybody, happy Thanksgiving. See you guys on December 9th.
Happy Thanksgiving.
Thanks very much.
Happy Thanksgiving.